Hello, I'm David Dalton. I'm Chief Executive at Salford Royal Foundation Trust in Greater Manchester.
And I'm Mike Farrar, the Chief Executive of NHS North West Strategic Health Authority.
We welcome you both, and just wanted to ask you a few questions on the NHS and how your quality improvement efforts are going there. It has been suggested that the NHS has a very close similarity and correlation to not-for-profit hospitals here in the US. So why don't you just kind of touch base. Mike, if you could maybe explain how the NHS is set up, the payer system.
Yeah, I mean, it's effectively a taxation-based funding, so it's funded by people's taxes, taken as income tax. The government then determines how much of that income tax they want to spend on health. And when they've decided that, effectively they allocate that money on a needs-weighted formula basis. So, for example, if you've got an older population that would have more health need, you would get more resources, and that's allocated to about 150 payers who are our primary care trusts, and they spend that money. So in the North West, 24 payers effectively spend £12 billion of taxpayers' money on healthcare.
Also, then, I guess you kind of reorganized the NHS, the trust system. How was that reorganized, and what are some of the challenges and benefits?
Yeah, probably about 10 years ago, the kind of thinking started that really having a state monopoly, so that you could only go to your local hospital or a local service, that was a good thing at one level because everybody got some coverage, everybody could go somewhere, but actually it wasn't really kind of promoting and incentivising each of those providers to offer the best services possible. So we've been moving gradually to trying to create a situation where providers have got to compete for the right to offer that care, and obviously our payers then contract with them on the basis of patients going through their services. And much more in the UK now, patients have choice about where they want to go for both their primary care, their community services, and and particularly their acute care. And a hospital like David's, which is a very successful hospital, is probably, I haven't seen his figures recently, but he's probably picking up business because increasingly they're telling the public about the kind of good things that they're doing, and people are going there because it's a provider of choice. It's getting great outcomes.
Okay, and you had mentioned earlier that the national priority is quality. How is that manifesting in your efforts across?
Yeah, well, David, I'm sure will want to come in on this one because it's very relevant for him, but nationally last year the NHS had its 60th birthday, and we took stock of where we were, and effectively we were doing well on some things, so everybody gets access to care, and we're reducing our waiting times really quickly. But the truth is it was a fairly universally average service, and we wanted to improve that. So we made quality the organising principle going forward for the health service over the next 5 to 10 years. And when the NHS does set its minds to things, it can do things quite quickly. So as of now, we have to have regional quality boards. We have to set up a quality observatory to help us report and improve quality. We're putting money in through our commissioners to incentivise quality, and the top performers can get 0.5% above tariff on top of what they would normally get if they provide the best quality. And it's a legal duty on chief executives to report to the public about the quality of services that they offer. And the final bit of that is that at regional level we have to publish our quality scheme and demonstrate exactly what we're trying to do. And of course one of the reasons why we've got this relationship with Premier is because we're using the previous HQID work that you've done as the bedrock of that. So it's quite exciting times for us.
And if I may, I mean, as Mike was saying, that until a few years ago we were a monopoly provider of services in our locality, so patients didn't have any choice; they had to come to my hospital. And 3 years ago we decided to ask the public what it was they wanted from their hospital, and they said that they wanted services which were safe, clean and personal, and that really was the stimulus for us to think about how we developed a strategy for improving the quality of our services to meet those express needs. And as you heard me say earlier, we've now launched that quality improvement strategy, and it will, I hope, take us to places we've not been to before, and dramatically improve the level of service that we're able to offer.
How are you addressing those three in particular? What programs have you put into place?
Well, we've decided to use those 3 words as our themes, and we've got 19 projects which are grouped under those 3 themes. and we're now looking at how we can involve the staff in thinking through the changes to practice or behaviour that they want to put in place in the departments or wards that will get the improvements that we're looking for. So quite a lot of those projects are to do with the Advancing Quality Initiative within the North West, which is about getting reliable evidence-based care into practice. We've got a lot about the reduction of infections, reduction in slips, trips and falls, getting a very personalised service in place as well. So a suite of projects, but the fundamental change is getting staff deeply involved in thinking through how they can make improvements at a ward or departmental level.
Can you give us an example of the empowerment of your clinical staff and what type of changes they have made?
Well, one example would be looking at how we identify a patient who would otherwise deteriorate, their health condition deteriorate quite dramatically, meaning the staff had to then call for a cardiac arrest team to come and respond. And staff on a number of pilot wards decided that what they wanted to do was to put to one side a lot of the technological equipment that measures vital signs and do that manually, so taking pulse and blood pressure measurement and so on. And I think because they were much more engaged on a one-to-one basis with the patients, they were also taking notice of what they were recording manually. And that's brought about on those pilot wards a 60% reduction in cardiac arrest calls. They were doing other things as well, so I just cite that as one example. And at the heart of that was staff trying to think through, well, what is it that they could influence? How could they think about providing care differently? And we encouraged them to test out their ideas, see whether they resulted in the improvement they were expecting or not. So on our wards now, you'll see process control charts which illustrate whether the improvement they were expecting actually took place when they modified it. So a lot of good things happening.
So great.